Welcome. Overview of platelet disorder. Essentially, I'm comparing von Willebrand disease, Bernard-Solier syndrome, Glanzmann thrombasthenia, TTP and HUS, thrombotic thrombocytopenic purpura, and HUS, hemolytic uremic syndrome. What is common? The pathogenesis of these conditions. I'm referring to this picture of Robbins, which is essentially summarizing function of the platelets. When there is exposure of von Willebrand factor due to vascular injury, the platelets get activated by two important receptors, the group 1B and group 2B. 1B, 2B, approximately. Remember it that way. Okay. Activation of group 1B causes adhesion of the platelet to the endothelial surface through von Willebrand factor. After the adhesion of the platelet, aggregation of platelets, that is sticking of multiple platelets to those adhered platelets, is through group 2B, a deficiency of which is Glanzmann's disease. The group 1B deficiency is Bernard-Solier syndrome, a congenital condition. Okay, both of them will give rise to chronic bleeding disorder. Von Willebrand disease is deficiency of the factor. The platelets are normal, group 1B is normal, but there is no von Willebrand factor. Then this deficiency leads to platelet functional disorder due to lack of adhesion. But there is also another congenital disease of defective group 1B known as Bernard-Solier syndrome. So it is something like von Willebrand disease, but not because of von Willebrand factor, but because of the receptor itself being abnormal. Okay. Now both these disorders are diagnosed by abnormal ristocytin aggregation. That is, a ristocytin is a compound which acts like von Willebrand factor receptor. So when we take patient's plasma and add ristocytin, if they combine with the ristocytin, then that means their group 1B is normal. Okay, with the von Willebrand factor. When there is deficiency of von Willebrand factor, as in von Willebrand disease, there is no aggregation by ristocytin. Now, when we add normal plasma, 50%, to the patient plasma and repeat this test, if it gets corrected, that means it is von Willebrand factor deficiency. If it remains uncorrected, that means it is receptor abnormality. So it will be Bernard-Solier syndrome. Now we will come to Glanzmann's thrombasthenia, which is congenital disorder of abnormal group 2B, which is necessary for aggregation of platelets, not adhesion. Okay, remember the difference. But again, they will give rise to same platelet function deficiency, the superficial bleeds, gum bleeds, nasal bleeds, epistaxis. Okay, so deficiency of Glanzmann thrombasthenia is detected in the laboratory by abnormal ADP, adenosine diphosphate, or collagen, or thrombin compounds. So in patients with Glanzmann's, ristocytin will be normal, whereas ADP aggregation will be abnormal. Okay, and the last but not least is acquired and congenital disorder of von Willebrand factor breakdown. Normally, von Willebrand factor promotes platelet adhesion, but once the injury is healed, the von Willebrand factor has to be broken down by ADAMTS13. So now that is the specific enzyme which breaks down von Willebrand factor. Now there are disorders, both congenital and acquired, deficiency of ADMTS13, and they are seen in thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. We have covered this in other videos more detail. Okay, so here I just wanted to compare. All of them leads to abnormal platelet disorders. Okay, thank you.